Hello, my name's Phil Hopkins. I'm from the BJA, the British Journal of Anaesthesia, and welcome to this latest BJA broadcast where we take the most recent issue of the BJA and select some papers from that issue and discuss them with the authors. And today we're discussing the June 2021 issue of the British Journal of Anaesthesia. And the papers we've selected for today have a common theme of paediatric anaesthesia, and they're from the Nectarine group of paediatric anaesthetic investigators. And I'm delighted to have with me today to discuss these papers Nicola Disma and Karin Becker, two of the authors from the studies. And first of all, could I both ask you to introduce yourself? Nicola, you go first.
Thank you very much for inviting me to this broadcast. My name is Nicola Disma. I'm Italian. I work in Gaslini Hospital, which is a large pediatric hospital in Italy. I'm associate professor at the University of Genova, and I'm part of the research committee of the European Society of Anaesthesia and Intensive Care. And of course, I'm one of the PI of the Nectarine clinical trial network.
Thank you. And Karin?
Yeah, hello, and thank you for inviting me to be part of this really exciting broadcast. My name is Karin Becke. I'm from Germany. I work in Knopf Children's Hospital, which is in the southern part of Germany. I'm head of Department of Anesthesia and Intensive Care. I'm speaker of the German group of pediatric anesthesia, and I was chair of the subcommittee 5 of the European Society of Anesthesia and Intensive Care, where we in that time started the studies under the umbrella of the clinical trial network together with Nicola. Thanks again for having me here.
Well, you're both very welcome. And perhaps, Nicola, I could start with you, and perhaps you could tell us how this fantastic Nectarine collaboration came about.
Okay, so let's start from the beginning. So we thought that it was good to do a neonatal and infant anesthesia study about 5 years ago. And of course, there is a clear link between the apricot and the nectarine, not only because we were using two different fruits, but because it was we thought that it was important to have a continuum from the apricot into the nectarine in order to have a deep dive on this neonatal population. Let me share this slide with you. So when we did the apricot study, we noticed that there was a clear correlation between the age and the incidence of critical events. I mean, the younger the age, the higher the incidence of critical events. But you also noticed that the distribution of critical events were completely different in neonates and infants compared with the rest of the population. As you can see here, the cardiovascular critical events were highly represented in the neonatal population. And on the contrary, in the rest of the pediatric population, the respiratory complications were the most representative. So in somehow, neonates are a completely different population and they deserve their own attention. That's why we thought that it was important to let's say, replicate or to continue the apricot with the nectarine study, focusing on very small pediatric patients, those who were born at the age of maximum 60 weeks of postmenstrual age, undergoing any kind of anesthesia. And we wanted to follow them up for 90 days in order to capture morbidity and mortality in this specific population. So it was definitely a new clinical trial network, which is definitely target on the neonatal population.
And I think, as Karin has already mentioned, it's supported by the European Society Clinical Trial Network, and there was some funding from the European Society. Is that right?
Correct. We applied for a CTN, a clinical trial network, through the European Society of Anaesthesia. We were successful, we got funding, and we also had a fantastic logistic support, which was, of course, the key factor for having the Nectarine study running smooth and successful. when we did the sample size calculation, we used the apricot population for the sample size calculation, and we got the number of 5,000 neonates and infants in the database. And actually, I'll tell you honestly that the Nectarine was even more successful than previous studies, because we had at the end 6,500 neonates and infants in the same database. So we have a huge database with a lot of very important and interesting data.
Well, obviously we're going to come back to the data in a moment, but sure. Perhaps Karen, if I could ask you, what were the main gaps in knowledge that you wanted to address with the Nectarine studies? So Karen, you just have to unmute yourself for a moment.
Sorry for that, yes. With the support of the apricot data, we clearly saw that neonates and infants requiring anesthesia are at increased risk of physiological instability and complications overall, and that the incidence of these complications and mortality is even higher than in the older children. So that was the starting point, to focus on the neonates. And the second point was that we didn't have ideas for triggers for peri-anesthetic interventions and associations with subsequent outcomes. That is fairly unknown yet. So the specific impact of the anesthesia technique and the anesthesia management has not been fully characterized in these old children. Although we know that neonatal surgery, particularly in preterm babies, is associated with adverse neurodevelopmental outcomes. You know that there is a broad discussion on neurodevelopment in children and its underlying causes, which are pretty much multifactorial. It's not the anesthetic, but it's the whole hospitalization, surgery, anesthesia, and all these factors together. The Safe TOTS initiative, which I have shown on this slide here, was established to emphasize the role of the conduct of pediatric anesthesia to prevent harm in the perioperative period and to promote safe and high quality clinical care. So this initiative considers that the quality of anesthesia management and other well-known risk factors have a far more impact on outcomes following anesthesia and surgery. So the primary aim of the Nectarine study was to identify the thresholds of these physiological parameters, as seen here on this slide: normovolemia, normotension, normal heart rate, normoxemia, normocapnia, normonatremia, normoglycemia, and so on, that were considered indicative of critical events occurring during and up to 120 minutes after the anesthesia. And the second aims were to evaluate morbidity and mortality, morbidity after 30 years and mortality at 30 and 90 days after surgery, and then to look at the data whether there is an association between critical events and the outcome in the end.
Okay, so yes, clearly a very complex situation with a lot of factors feeding in. And Nicola's already mentioned about the size of the database, but one of the things that must be really difficult is enabling your data to be truly representative of the European population in this case. So how representative do you think it is, Nicola?
That's a very good question. Actually, I cannot provide a precise answer, but let me show this slide. So this is the distribution of the patients which were included in the Nectarine studies, study across Europe. You will see from this slide that almost all countries in Europe participated in the study with different, of course, contribution. And honestly, when we do such kind of studies, you can choose collecting critical events through a registry, which is usually a self-reporting critical events, but we wanted to do on purpose with a prospective cohort, observational cohort studies. Of course, the result of a cohort study is that people are really focused for 3 months to collect the data on that specific population. So differently from a registry, usually we have an over-reporting of critical events rather than having an under-reporting, which is typical of the registries. So coming back to your question, I can tell you honestly that I believe that the Nectarine study represents practice in Europe. Of course, it might be the tip of the iceberg, because we don't have any information about those critical events which happened and were not reported or simply were neglected. It means that people did not react to that critical events. And of course, we don't have any information regarding those centers where neonatal anesthesia is performed and they didn't want or couldn't participate to the study. At the end of the day, again, I think it is representative. We got very interesting answers.
So were there any, and perhaps Karen can answer this one, were there any countries where there were obstacles for centres participating in the study?
Yes, of course. That's a good question. There were many obstacles, and some of them due to the political and the economic situation, because this is very inhomogeneous in Europe, and some centers really failed to participate because of these obstacles. Many of the countries had difficulties to participate a priori, but they had some kind of solution afterwards. Other countries and centers could start first, but then got problems, for example, due to staff shortage for research. There were many different fields with obstacles, but one of the most remarkable example of an obstacle is the different national requirements for obtaining ethic approval. In some countries, ethic approval and informed consent was mandatory, in others not at all. So we even found completely different specifications within one country. For example, Germany, we have, I think, more than 35 different specifications in the different counties. So unfortunately, some of the countries dropped out because of consent difficulties with their institutional ethical committee. And we think that this is a problem for all multi-center studies which go across the borders, particularly in Europe, but also in United States, in North America. And these problems are politically well known. The European Parliament already invited us, the European Society of Anaesthesia and Intensive Care, some years ago to a workshop with the headline "Improving Outcomes for Critically Ill Children," where we clearly addressed all these points. And we did that again after the Apricot study, because there we found the same obstacles again. Unfortunately, you know that these topics are not always given the importance they deserve because political events are overlapping. For example, the day I went to Brussels for this EU Parliament, that was the day where the Brexit started in Brussels. So there was no time and no room for pediatric anesthesia problems. But I think we have to keep these issues and to tell the politics that this is really important for the future and for especially for the future of multi-center studies all over Europe.
Yeah. Let me add a few words on what Karin said. I think this is really important. And as Karin said, we went to the European Parliament a few years ago, and Karin presented this issue, and we really need harmonization of practice across Europe. But the good news, if I can say that, is that the European Society of Anaesthesia and Intensive Care is already participating in collaboration with the European Parliament to get simplification on the ethics committee rules and the bureaucracy across Europe. And I think this is really an important and urgent matter which we should deal with in the near future.
Absolutely. There is an urgent need to harmonize these requirements and to cooperate in cross-national networks. And this is what we now did the second time with the Nectarine study after the Apricot study, and which is done in many other countries or in many other institutions. You can see on this slide, for example, the PD registry in North America. You can see the PAUSE registry now with COVID-19 pandemic questions. So from our from my view and from Nicola's view, there are no barriers or borders in science, and we have to go on in these international networks to increase the numbers of patients and to further promote clinical research.
Yes, I think one of the things that's been forgotten, isn't it, is that there's been a lot of emphasis on harmonizing trials in relation to drug trials, pharma-sponsored drug trials. but perhaps those that are more investigator driven haven't received the attention they should have. I'm sorry to hear that Brexit had another downside. It's got a lot to answer for. But I hope it's not going to impede these efforts for harmonisation, because UK anaesthesiologists are really keen to be involved and to stay involved with our European friends. So fingers crossed there. Now, perhaps if I could change the emphasis slightly. As you know, I'm not a paediatric anaesthesiologist, and neonatal anaesthesia is so specialized and so complex. So even for people like me, it's difficult to grasp sometimes the technical and medical challenges associated with anaesthetizing this age group. I just wondered whether you could give the viewers some idea of what it's like.
I will start saying something and then I will pass the word to Karin. So see, this is just a picture which I took from my hospital a few years ago. And this is a tiny neonate who had an acute bowel obstruction, and he underwent surgery. So this situation for those working in a pediatric hospital is not that unusual. It means that it's really challenging. It's really challenging from many aspects. What I'm saying is that it's important to have a close evaluation of the child before providing anesthesia. We have to be ready with the expected and unexpected. We also need to have a plan A and a plan B in mind. We need to have the correct device for these tiny children. So we cannot use those that we are using for adults or for older children. So we need a specific device and specific technology. And on top of this, we might need to have the correct expertise and seniority. And we can find all of these only in a dedicated hospital. This is what we are saying for years and years. It's important that the most fragile population, and by referring to neonates and prematures, they have to be anesthetized, and of course they have to receive surgery in dedicated centers. This is really important, and it's crucial for improving the outcome of these children. Having said this, let me show what happened few days ago, literally a few days ago in my hospital. I work in Gaslini. And this just to give you the complexity of a child. This is a small infant undergoing thoracic surgery. Now the new trend is to perform thoracic surgery in my hospital robotic. And of course the surgeon wants to do robotic. He's a very skilled, he's excellent surgeon, but he needs to have the lung excluded. So we performed induction of anesthesia and intubation with video laryngoscopy. There was all the equipment ready behind for robotic surgery. And then, of course, we needed to have a full invasive monitoring. And we did, of course, arterial line cannulation with ultrasound. We were ready to do that. And then we had to exclude the lung. So we put a bronchial blocker in the tube. We had to check that it was correctly positioned. And once surgery started, this was the situation. So we had all the arms of the robotic on top of the child, and we were pushed away from the child. What I mean is that we are adding complexity on top of complexity. So we are facing with very complex children. We do need, again, the device, the technology, but we do need to have the expertise for doing such kind of anesthesia. And then we need to have reliable monitoring, because once they start surgery, we are again far away from the child. There is no possibility to have a physical contact with the patient. So we need to have reliable monitoring for these children. This is just to give you the idea of the complexity.
So how long did that surgery last, Nicola?
2 hours.
2 hours.
2 hours of surgery, or pre-surgery plus anesthesia, more than 3 hours. Mm-hmm. Well, again, if you trust the surgeon, you can do even more challenging surgeries. But of course, it's important to have a smooth communication between teams. And when I'm saying teams, I'm referring to anesthesia, surgery, and the nurse staff. Mm-hmm.
So you need a lot of confidence in your initial setup.
Yeah, correct. And then you need your plan A, which means that I want to do this, this, and this. And if something goes wrong, you need to have your backup plan ready to start. So that's really important. You know, Phil, that we divided our Nectarine study into 2 different papers. One is completely dedicated to the main study, which is critical events in neonates and infants, plus morbidity and mortality. And the second one is fully dedicated to part of the primary outcome, which is difficult airway management in neonates. So in order to give you the idea, we prepared this small video clip, which we usually use for junior doctors. And I'll tell you honestly that part of the information which are provided in this clip come from the Nectarine study. So we usually start, of course, with pre-oxygenation. And then once the child is pre-oxygenated, we start doing anesthesia induction. In this case, it was an IV induction. And induction, yes, so this child already had induction. And then we clean the nostril. Usually we do 2 hands mechanical ventilation during induction in order to continue having the correct ventilation and oxygenation throughout induction of anesthesia. We set up the ventilator in order to have the ventilator ready for ventilation once the child is intubated. And then we provide oxygen all over the time. It means that we are now implementing the use of high flow nasal oxygen during intubation, and we do video laryngoscopy intubation in every neonate, because this is the new evidence. We already have evidence from the VC trial. We got more evidence from the apricot and the nectarine. We do need to use this specific device when we are facing with intubation in very small neonates. This is really important for teaching. It improves the view of the glottis, and it enables the staff to collaborate with you while you are doing the intubation. I think this is a critical point. You will see here that the tube pass through the course, and then there are the final check. They check the correct position, you check the correct ventilation, and then you, of course, you go for coffee. Karin.
Yeah, Nicola, thank you very much for this fantastic little film where we saw what really is important. And I think when we talk about technical and medical devices, of course, we can do almost everything, even in the very small babies, but that's the one side of the medal. The other side is the individual and the institutional competence. That means monitoring is good, but you need people that take care of the baby and who know how to use all that monitoring equipment and technical devices. So it's no problem to use baseline monitoring as we do in adults. You know that ECG, pulse oximetry, non-invasive blood pressure, CO2, and recap time are very well evaluated in children as well. But we also have the possibility to extend that monitoring as we do in adults, for example, with invasive blood pressure. You showed us how you did that arterial line with ultrasound, and central venous oxygenation via a central venous catheter. We use a lot of near-infrared spectroscopy, which is really a fascinating monitoring device. And I think there will be a lot of data in the next years, particularly in very small children, in critically ill children. We use sometimes the EEG, which is good in children who are older than 1 year of age. And of course, in children with complex congenital cardiac disease, the transthoracic echo. So there's one problem, which is pretty different to what we see in adults. We don't know exactly how the normal values are defined in the very young children. And that was, again, one of the aims of the Nectarine study, to take a look at this database. So it is all the more important to record trends in the whole perioperative course, which means you have to start with measuring the blood pressure as soon as you can after induction of anesthesia. And significant deviations from the initial values should always be viewed critically in order to maintain the so-called physiological homeostasis, or the 10N quality checklist, which I showed from the Safe Tots initiative.
Thank you. All I can say to that is wow, because I mean, you're doing everything and more that we do with adults on a much smaller individual, and it's just a wonder how you manage to get all your monitoring devices onto such a small patient. It's fantastic, but I'm quite pleased that I don't do neonatal anaesthesia. Okay, so if we go back to the study, and Nicola's already mentioned how much data there is, and that the papers are jam-packed with data. And for the reader, it's often difficult to pick out what are the most important things. But what I like to know is what the authors really think. So which of the data do you think are the most interesting? And if there are any that were particularly unexpected for you?
Okay, let me answer this question. So in one slide, I'll tell you honestly that we know before starting that neonates and infants are at high risk of having critical events, but we didn't actually expect it to have such high incidence of critical events. So we had 35% of our population who had at least one critical event during anesthesia, which is very, let's say, alarming situation. And then in the postoperative period, 16.3% of these children experienced one complication. The most represented was the respiratory complication with like pneumonia or failure from weaning from the ventilator or any other respiratory complication. But again, 16% of these children had at least one complication in the 30 days after anesthesia. And then we ended up having the 3.2% incidence of mortality of the overall population at 90 days. Again, these are very high and, let's say, alarming numbers. In regards to difficult intubation, we had 5.8% of the population having a difficult intubation. But what is really important is that 2/3, more than 60% of these children having a difficult intubation episode, they also had a concurrence of a serious complication during the intubation. What I mean is they had at least severe desaturation below 85% of oxygenation, and they also had concurrent bradycardia. So this is scaring. What is reassuring is that we wanted to do a comparison with we wanted to compare the incidence of morbidity and mortality between those children having had difficult intubation and those who didn't have difficult intubation. And actually, we noticed that there was no difference in the outcome despite the occurrence of difficult intubation, which means in somehow this is quite reassuring. It means that even if we are facing with difficult airway management, we were able to complete the procedure without bringing more harm to this child in order to have a positive outcome. This is actually all the data that you can find in the paper. And on purpose, we wanted to present all the data in the online supplemental file in order to have this data available for those that were interested to have a deep dive in this data. What is completely unexpected in somehow is that when you have the so-called composite adverse event, it means the co-occurrence of hypotension, hypoxemia, and anemia, these three events at the same time during the same anesthesia, then you ended up having an increased mortality of nearly 20 times, which is completely unexpected. And of course, an increased morbidity of 3.5 times. Okay, these are the data which I'll tell you honestly were unexpected, but gives you the idea that the way we are doing anesthesia might have a significant impact on the postoperative outcome. So I'm pretty sure that if we are able to early recognize the problem, treat properly, then we will improve the outcome of these neonates and infants. That's for sure.
One of the issues with this type of data collection, though, is that it's very easy to demonstrate two variables are associated with each other, but much more difficult to try and find variables that might be used to predict an outcome. How did you face that challenge with your data?
Well, that's really a very important question regarding particularly prospective observations. I'm not an expert in epidemiology or statistics, but I think we agree that with this kind of study design, we will never be able to prove causality 100% according, for example, to the Bradford Hill criteria. So from our view, the results of the Nectarine study, they represent the current practice and behavior of anesthesiologists managing neonates and infants. And of course, there are a lot of limitations and confounding factors. There is bias, and particularly public health and medicine are complex interventions where you cannot have this causal relationship underlined. So our aim was to integrate the experience of the clinician. This is what I call this reflection of current practice, to get a huge amount of data of values of the patients, and then to get the best available scientific information together, which we call today evidence-based medicine. And that is the case in very small children. There is not much evidence, and we just have to give the data in these thoughts about how to promote safety and quality in pediatric anesthesia. So yes, it is very difficult to get causal relationship, and we have a natural bias in these studies, but it's a huge mass of data, and I think we have some kind of reflection of the current practice and therefore the best evidence we have.
No, I don't think you should make any, or even attempt to make any excuses. I think recognizing the limits of your data is such a vital thing that is often not done particularly well by authors who try to make too much of the data. I think the data here, as you say, certainly stands for itself. So I was just wondering, you've obviously a huge undertaking, fantastically executed to get these studies done and published. If you were to do it again, Nicola, what would you do differently? Don't
do that studies. Okay, so having said this, honestly, when we started with the Nectarine, we were very enthusiastic. We recently had the successful apricot study, and we said, okay, everything will go well with the Nectarine. We already have a fantastic network. We have enthusiastic people collecting data. Nothing can go wrong. And actually, the Nectarine took longer than expected for two reasons. One is that when we finished collecting data, we had to face with 6,500 patients, and for every child, we collected more than 300 items. So it means 6,000 multiplied per 300. So we ended up with the first cleaning of data with 10,000 errors, which is normal life. I mean, it is normal life, but we didn't know before doing the study. So we had to spend nearly 2 years to clean the database. And in order to get the data fully corrected, we wanted to do the cleaning twice. So we did the first round of cleaning, and once we cleaned the data, we wanted to do again in order to make sure that everything was correct. So this stuff took 2 years. So if I have to do the study again today, I would have done the cleaning plan before doing the data collection. This is a strong message. So I know it takes time. Spend 6 months for having a cleaning plan ready, which means that once you are entering data from the paper case report form into the electronic case report form, you can get the data cleaned immediately. So you can come back to the local investigator and say, okay, this weight is wrong. Can you tell me the correct weight of this child? And then you clean the data and you have everything right. So this is the first message. So do have the cleaning plan in mind before starting everything. So it's better spending 6 months before rather than spending 2 years for cleaning the database. Well, this is something. On the other hand, honestly, we got some criticism about the huge amount of data we collected. So the usual message is collect the less is the best. I'm not completely sure, because thanks God, we spent 2 years for cleaning the database. We published the 2 papers in the BJA, but now we have a lot of interesting data that we are going to analyze with the ancillary analysis. And on top of this, we have specific data on subpopulation. For example, we are looking at the pyloric stenosis. We want to look at the esophageal atresia. We have enough number for simply, for example, calculating a sample size and doing a new study on that specific population. So we have this data, and they are more valuable than gold, honestly.
Well, you've already preempted that question, because with such a rich data source, we really are looking forward to your future analyses, and I hope some of those at least are going to come to the BJA. We'd obviously be very interested in publishing high quality data like that. As you probably guessed, one of the things that really interests me is differences in practice between countries and differences in circumstances between countries. And it seems that you've been quite careful not to evaluate those and publish those. What's your feeling about the differences in outcomes and practice between different countries?
Is it for me or for Karin? Karin, do you want to answer?
Yeah, we saw a lot of differences between the countries. That started with the Apricot study. Just to give you an example, we found more than 100 different ways to induce anesthesia in children. We found more than 40 different fluid types for fluid therapy. And that was the point where we said it is so important to harmonize standards and guidelines and to give people all over Europe just some kind of standard operating procedures for important processes like fluid therapy in children. We know that this is really outcome relevant, and we started in 2010 with a European consensus statement on fluid therapy, for example. So that's really important regarding the differences in the conduct of anesthesia. With the differences regarding the complication rate or the incidence of severe critical events, we didn't want to have a very clear benchmarking in the paper, because that's always critical. You don't know how sensitive the data was gained in some countries, or how the bias was, were there only expert centers, dedicated pediatric anesthesiologists, or were there also district hospitals. So you cannot really benchmark one country to the other. Nevertheless, it's really important for the nations, for the countries, to get their own data, to look at their own data. What were the main problems within the countries? And then they can have a benchmark to the overall complication rate, for example. I think that is really, really of high importance. And that will be, of course, ancillary studies coming from the countries. For example, in the UK, which participated with a high number of centers. And we are really looking forward to read about the numbers from the countries.
And that's in hand, is it?
Yes.
Those ancillary studies. That's really, really important. I think I agree with you there. Okay, so what about the future in terms of future studies? Nicola, you said never again, but I don't believe you. I don't think you can resist. So what about the future for the Nectarine group and future trials?
So out of Nectarine, why I'm giving this title? Because as for the apricot, there's always a long shadow after doing such big studies. So we published the apricot in 2017, and we did several ancillary papers which were published. One of these was published in the BJA, actually. And still now we are doing something on the database, because we built up a collaboration between our group and the John Hopkins University. And we wanted to do a machine learning and artificial intelligence study on the apricot database. What does it mean? It means that we wanted to shift the attention from the risk factors of a population to a specific risk which can be attributed to that specific child. So with the machine learning theories, we were able to produce an algorithm which is in somehow able to predict the risk in that specific patient. So this is a new way to approach data. It's very interesting. I'm not saying that it's the best way or the wrong way to do analysis, but it's another way to approach data. So in somehow, I think that this collaboration was quite interesting. We learned quite a lot about machine learning and artificial intelligence. And I think in somehow, even for the Nectarine, we will do a similar project with John Hopkins or other universities which are interested in doing artificial intelligence studies. Let's be a little bit more specific. So the collaboration is established. This is the key factor. So we did the apricot, we did the Nectarine. We have a huge network of centers participating pediatric anesthesia trials. With apricot, we had 360 centers participating. With the Nectarine, slightly less. But once the pandemic started and we needed to have data collection, this is the post-COVID-19 studies, we expanded the collaboration beyond Europe, and we started gathering collaboration with the PEDI collaborative group or South American groups and Australian groups. So the strong message is that the network is there. There are no barriers. We want to continue collaboration and we want to expand the collaboration. There is already plan to do a new study, which is called Blueberry study. There is another in the pipeline, which is the Prominent study. And all these studies will consider collaboration beyond Europe. So there are no barriers, there are no borders. US is welcome, South America is interested to participate. There are some keen collaborators in Australia, and one day we'll get more collaboration with China and India, which is another part of the world which needs to come on board. So again, there is new plan for continuing our research. We want to establish officially this group. So the aim is to submit a proposal to the European Society of Anaesthesia in order to get the pediatric anesthesia research network as an official research group for the for pediatric anesthesia. What does it mean? It means that the network is available not only for me, you, and Karin, but for all those people that have great idea and they want to develop their project through the network. So the network is open to everyone.
I think that's so important, Nicola. That as you've already mentioned, pediatric anesthesia research has always been a little bit of a Cinderella activity in terms of research, because it is so hard. And you know, I think that's a fantastic initiative. Karin, what about you? What are your thoughts on the future?
Yes. We will move on with that pediatric anesthesia research network. We achieved a lot of our aims, but it's time to move on. And hopefully we will get in contact with more countries, with more people in pediatric anesthesia. And we will collaborate with different institutions, which is not only the European Society of Anaesthesia and Intensive Care and its clinical trial network, but it's also the International Safe TOTS Initiative. It's the European Society of Paediatric Anesthesiology. And there are so many people who are really active in pediatric anesthesia as well as in science and in studies. So that's a good basis to move on. This is the point where I like to thank Nicola once again for this hard work. That was really fantastic, Nicola. Thank you so much. And I think it's also the time to give again a big thank you to all the contributors in all the countries. I think we had, I don't know the exact number, maybe you remember that, Nicola. The staff of the European Society was also very valuable. We couldn't have done this study without all the people in the Secretariat and in the clinical trial network in Brussels. And of course, all the authors, all the members of the steering committee with their brilliant ideas. That was really a successful story. Thanks again, Nicola.
Well, thanks to both of you, Karin and Nicola. And yeah, indeed, I really echo, I think the contribution of the collaborators, the people who collected the data, because without them, we wouldn't have the study, and it's a fantastic effort from you all. So congratulations to everybody, and best of luck with the future of the group and the network. I really do hope you you carry on so successfully. So thanks again for those of you who have watched. I hope you found this broadcast interesting. Please do go and read the papers. You'll find all the declarations of interest relevant to the authors on the papers, and of course the funders are acknowledged, very important. Without the funding, these things don't get done. So we'll see you again soon, but for now, bye-bye.